Welcome back to another episode of Move Well, Live Well, Perform Well. I'm super excited to have Dr. Jon Houghton here with me today. Jon is a bit of a guru. He's a sports medicine consultant at the Fortius Clinic and Chief Medical Officer for both Surrey County Cricket and the Football Association of Wales. He doesn't like to sleep much. He's got extensive experience across elite cricket, football, athletics, and military performance environments. He's one of the UK's leading clinicians in the diagnosis, prevention, and rehab of stress fractures, including PARS injuries in cricketers and lower limb rehab injuries or lower limb bone stress injuries in runners, footballers, and endurance athletes. He's known for his ability to blend high-performance sports medicine with practical, adaptable strategies for everyday patients. He's got a particular interest in understanding why bones fail, how biomechanics, training load, red S, hormone health, and recovery and behaviours and tissue tolerance all interact. He also uses sort of advanced sort of bone healing modalities and sometimes some pharmacological support. And so Jon's work expands across all levels of sports and our weekend warriors as well. And this really gives him a unique perspective on what drives rehab. So, yeah, with all of that in mind, which is a bit of a mouthful.
Yeah, absolutely.
Welcome here.
Yeah, thank you very much. Thanks for inviting me and a wonderful intro. Thank you. I'm not sure all of it's deserved, but...
Cool. Perfect. So, Jon, I'd love to dive in today to just discuss about some rehab principles, the difference you often see across different athletic populations, so different sports and some of the bits that are different in terms of rehab parameters, but also different levels of athletes and how they might need different rehab pathways.
Yeah.
And then break down some of the bone stress injuries that we're seeing a bit of an epidemic on.
Yeah.
It appears at the moment. So with that in mind, you've worked across elite sport for a lot of years. So how's that shaped how you think about rehab and recovery?
Yeah, so I think I'd probably say, if I'm honest, that my military experience shaped my idea of rehab more. That was what came first.
Okay.
I came through a NHS training program in rheumatology.
Yep.
Always wanted to do sports medicine. Got to consultant level and realised that what I was interested in, what I was trying to achieve, was not something that the NHS really offered a great deal. So partly by chance, kind of ended up at a place called Headley Court, which is a tertiary military rehab hospital. And I think that, my great teachers there, like John Etherington, who was my boss for a long time, he was one of the guys that kind of introduced me to military rehab, which was very MDT focused.
Yeah.
So it was that first time that we were working.
So
multidisciplinary team.
Yeah.
So within a team, you would have a number of health professionals, and some of them were military, some of them were civilian. So I worked in force generation, which is keeping soldiers and airmen and Navy healthy.
Okay.
But also worked through the whole of the Afghan conflict. So we were dealing with a lot of complex trauma injuries.
Okay. You would have seen some interesting stuff and some
pretty horrific
stuff.
injuries.
Yeah.
We would take some of those patients. I tended to work when our complex trauma team had spent a long time with them. So most of the guys and girls that I was seeing were functioning a little bit better, but still some serious injuries. And I worked in a team for several years, which had consultants. We had some junior docs, but we'd also have physiotherapists, some military, some non-military. We'd have something called an exercise rehab instructor. Which is like a physical training instructor, like a PT, but they have additional medical military
knowledge.
Rehabilitation knowledge. We might have an occupational therapist. There'd be a podiatrist working with us, and in the complex trauma, more in the way of nursing also. So it was really a great opportunity for a bunch of people to come together with shared goals, different skill sets, and everybody kind of knew their job. And for me, it was the first time that I saw how an MDT should work.
It's not that dissimilar to what you're trying to do in a sports environment.
Absolutely. And I think that what the best teams that I've been involved in, I've been really lucky to work with some really good teams, and Wales and Surrey being two of them. We have a bunch of individuals that form the part of that rehab team.
Yep.
Who everyone has their own unique skill set. And everybody's skill set is respected and listened to, and everybody brings their own thing, and you kind of stay in your lane for most of the time, but everybody has a chance to kind of feed into it, and I think that's the best way that teams work.
Yep. Okay, and that experience, how has that sort of developed your sort of base principles about what led to good rehab? Because I think, we see a lot of patients probably between us whereby they might have had some rehab, they might have seen a physio, but actually it was awful. it was not what I would term appropriate rehab or physio. How did that time there sort of bring those ideas together so that you had an understanding of what could be achieved for individuals?
So I think a lot of that comes down to communication. So obviously, we both work in environments where we've got some people around us, some team, but I rely a lot on relationships that I've built in private practice over the last kind of 15 years with physiotherapists, podiatrists, PTs, etc., where if you're clear with your communication and the communication is two-way, then the patient understands what they're doing and what the goals are, and everybody's on the same sort of page. But you're absolutely right. The worst times are, if I see somebody 3 months after an initial consult and I'm sort of saying, okay, what have you done rehabilitation-wise? And they can't tell me, they can't really remember what they've done or explain it clearly, then you kind of know that there's been a breakdown in communication.
Yep. Okay, cool. So when someone gets injured, what are some of the key principles that lead to a good recovery process? I mean, you talked about communication within an MDT.
Yeah.
Is there anything else that you have in mind that, okay, I tend to simplify it a lot. Calm shit down, build shit up. A lot of the time we've got to get people stronger again or more resilient because they break with overuse type injuries if we're talking bony stress injuries.
Yeah.
Are there any principles or key things that you look at for the...
Yeah, and again, I think it comes down to what's your role in the MDT. I very much see my role as primarily making a diagnosis, and I've failed at my job if the patient doesn't understand what's wrong.
Yep.
If they don't have a diagnosis, if somebody says to them, "What's wrong with you?" they should be able to explain that. If they can't, then I've failed. So it's using diagnostic imaging, blood tests, etc., and having a clear diagnosis, and then making sure that the patient has a clear plan and a bit of a roadmap of what might happen. And that can also include, what do we do if things start going wrong? It's a plan A or a plan B.
Yeah.
And obviously there are some times when you don't really want to discuss the plan C. Sometimes it's not that helpful to say, if you're one of the 1% where everything goes wrong, you tend to couch things for the majority of people, but they need a clear diagnosis, a clear plan of what's happening next, and really understanding their goals as well.
Yeah. Do patient expectations feed into that pathway process as well?
Yeah, 100%, because I think it should be goal-based. And so if a patient is coming with very high expectations of their recovery, for example, or what their physical performance can be, then you have to be honest with them about whether that's achievable or how long it might take to achieve that, or the risks of not achieving that. There are some people who genuinely come and they understand that there's an injury, but their long-term goals are not hugely difficult. And often it might just be a concern. They might have seen somebody else and been told, you have this bony injury and they're worried. They're worried, is it a cancer? Is it something that could come back? Or is there something wrong with me? So I think, again, part of my job is to explore what are their main concerns and then address the plan and the goals to reassuring those or addressing those concerns at the very least.
Yep. Okay, cool. So what are the biggest differences between these elite athletes' sort of rehab pathways and how recreational athletes or even just general public go through their rehab? Can you explain that a little bit?
Yeah, I mean, I think obviously professional athletes, the resources are much better on the whole. Not every sport. I'll be honest. There are quite a few athletes that I look after, even up to Olympic level, who don't get a great deal of funding. They're still doing a job. They're still training.
Some of the Olympic athletes,
absolutely,
it's a hard gig.
It's definitely a hard gig. So on the whole, though, they are slightly better resourced. And so on the whole, they will have a better structure for their rehabilitation, i.e. who's going to be involved in it. They might have additional help with programming. So it might not just be...
team.
Yeah, absolutely. They might have access to S&C, nutrition, gait analysis, some of the things that not everybody would have access to. So I think resource is important, and often it tends to be a lot more planned out. It's a lot more structured on the whole. And that's one of the big advantages to a rehab program that the elites will have over a non-elite.
Cool. But actually, a lot of the time, it's the same principles for the general public compared to the elite athlete, but they're just taking someone to a different level. Would you agree with that?
Yeah, to some degree, absolutely. Like you've said, often there are inherent weaknesses that need to get strong. You need to calm pain down because pain inhibits function and strength. And again, with the elites, you're often, though, preparing them for a much more intense amount of workload that they have to resist on the whole. But, you'll see many of these people who are doing full-time jobs and doing, Ironman, triathlon, high-intensity sport to a good level. And so that's part of that rehab process, though, is how to what degree do they need to be prepared to tolerate load.
Do you see a big difference in mindset between, say some of these elite athletes in your setups versus, our Joe Bloggs, who's a patient who might have an injury? Certainly facilities and environment and what they have access to is a big difference. But does mindset play a role in that rehab process?
I think mindset's important in recovery. What I would say is that it's not elite athletes all have this mindset, which is why they're successful and non-elites don't. I think I meet plenty of non-elite athletes who have a fantastic mindset and are hugely dedicated, very organized, very professional in the way that they approach their hobby or their sport. And similarly, I've met quite a few professional athletes who are not maybe so professional in the way that they approach their recovery, and their mindset is maybe not so strong. I think in team sports, you can, talent can carry you. In a team environment, sometimes, there'll be players who, don't have that really good mindset for recovery or for conditioning, all those other things. Individual athletes tend to fail quite quickly if that's the case. But I think that
there's no hiding in that situation.
Absolutely. But on the whole, most professional athletes have a pretty good and positive mindset towards how they prepare themselves and how they recover and look after their bodies. But they're still, just as, they're not immune to the fears and concerns and doubts that all of us have when we're injured.
Everyone's human.
And the fears,
completely. So you work across quite a few different sports.
Yes. Yeah.
Do you see differences in the way you need to manage their rehab pathways? Comparing, clearly there's biomechanical differences
Yeah.
and strength differences
Yeah.
or load differences between cricket and football.
Yeah.
But are there real differences in terms of how you need to manage them or that pathway?
I think that traditionally there were quite big cultural differences.
Yep.
And I think, even if you go back 20, 25 years, even if you look at a sport like rugby,
Yeah.
there's very different culture behind how they prepared and how they recovered. I think that as time goes on, and we've all got access to information, the internet. You see how people train, you see how people recover. I think most sports are all heading in the same direction now in terms of professionalism. What's good for you, what's not so good for you. I think that even in cricket, I've seen in the 10 years that I've been involved with Surrey, the professionalism and the athleticism has changed massively, and some of that is white ball cricket. Changing what's required. It's a really intense sport now.
It's much faster.
Absolutely. And the top athletes, and this is where money comes in. When money comes in and the prize money goes up, and it's then you see the sports change. And people change the way they prepare and sort themselves out. I think, culturally, again, sometimes in football that there'll be some players who sort of don't want to lift heavy. Because it gives them DOMs and they don't like training with DOMs. And some sports, those sorts of things can carry over as...
Is there a difference between your footballers and your rugby players, or your cricketers and your footballers, in terms of that ability to tolerate pain? Because there's this slight perception there.
I've got to be careful what I say. I think that, like a sport like rugby, they are... It's so inherent now, the strength training. So the sport itself requires them to be very physically, potentially aggressive, robust, and they're not going to get very far if they're not like that. I think within football, you still have those mercurial players who don't necessarily have to be as strong, don't necessarily have to spend so much time in the gym. But, I think, as I said, what you see is globally, most of the athletes now coming into the Premiership are that. They're athletes first, who are also very, very good footballers. And there's very few players now that can get away with just being skillful and talented. They've got to be athletic as well. The demands of the game, the way that those sorts of sports are moving.
Stress fractures.
Yes.
Why do bones fail? I suppose, in overuse type injuries, you work with a lot of cricketers. So fast bowlers tend to see quite a lot of pars injuries, pars stress fractures in fast bowlers. Why are we seeing that? We're also seeing a huge number of those in younger footballers, for example, even rugby players. Why do these bones fail?
I mean, in simple terminology, the bones fail because the load that's being applied to them is greater than how they can tolerate that load. Now, everybody's bone is constantly turning over, and I think it took me a while to get this concept when I was a junior doc, and you kind of just think, oh, the skeleton's a skeleton, right? It's a fairly inert structure.
But it's not.
But not at all. So calcium levels in our blood need to be a very specific range because the calcium does a lot of stuff with muscle activation, nerves, etc. And so we're constantly borrowing calcium from our skeleton, dissolving small parts of the skeleton to make sure that the calcium is correct. And then we're laying it down when we've got an excess, and that bone process has got cells that break down bone and make new bones. So we're constantly in a cycle. And essentially, bone breaks down when either the stimulus to dissolve bone is too high, which is often load, and maybe the nutrients and the time and the recovery is not there to activate the cells that make new bone, and you get an imbalance. And that can be a global imbalance, or it can be very specific to one area that's being successively loaded and overloaded. And the bone can tolerate an awful lot. And you know, we talked about fast bowlers there, and we might come on to DEXA scans and bone density later, but fast bowlers have some of the greatest spinal bone density of all athletes.
Well, gymnasts are up there as well, I think, aren't they?
Yeah. So,
because of that pounding.
Absolutely. From the load that they have from their bowling, their bone adapts by getting stronger. So we know that exercise improves bone density, and yet they're still fracturing their pars. And they might have, we can explain some of this later, but they might have a T-score that's super maximal. They're in the top 1% in the country, and yet they still get a stress fracture. So it's a question of the load that it's being asked to go through versus what it can tolerate.
So there's an imbalance there. It's often load related. But sometimes it can be an imbalance in sort of hormones, in nutrients going into the system. And in young athletes, particularly, do you see it more being biomechanics and load related, or can there often be multiple combinations that lead to these bone stress injuries?
Multiple things that feed into it. What I would say is, I suspect that the sort of epidemic of adolescent bone stress injuries that we're seeing is probably the two main drivers are the load. And, I remember when I was a kid, loved football, but there just wasn't the opportunity to play football to the extent that some of the kids do now. You're playing in the park, but, it got dark. Now you've got academies.
There's lights everywhere.
You've got training facilities, lights. And so some of the kids that I see, you ask them, right, let's go through all your PE, all your school sport. They might play for a local club. They might play for an academy. And they might be having several double days of sport, several days of triple days of sport, no days of no sport. So the opportunity for load is much, much higher. And that's organised sport. So the intensity and coaching and skill, all those things have gone up in our juniors. Rather than just playing. And I think that the load is massively high. The second thing, which is probably the other biggest problem with the adolescents, is the actual nutrient intake. So they're just not getting either enough calcium, vitamin D, the key components, or the other key component is calories.
Protein,
really important, but it's calories really. It's have they got enough fuel to sustain what they're doing. And the problem is that, if they're running between, they might have breakfast at home, or they might skip breakfast. They might then, they're at school. Are they eating the school dinners? Are they, are they chucking away the sandwiches and getting snacks? They then go straight into sport after school. Have they eaten before then? They might then have another session before they actually eat and refuel. So it's an imbalance of, for me, it's calories is probably the biggest thing. Plus the load that they're being asked to be put under.
Because these kids, teenage kids, often if they're exercising a lot, probably need 3,000 plus calories a day.
Oh, plus. Yeah, it's huge. And huge numbers.
They're a lot of the time just not getting anywhere near that. Which is where we get that sort of simple sort of calorie in, calorie out deficit.
And what we see is a lot of the bone stress injuries that they get are shortly after the periods of maximal height velocity. So when they're growing quickly, that's when they really need the excess calories, and they haven't quite adapted to that. Their bone is growing. I always kind of just say, look, bones are softer at that age because you're kind of growing. The growth plates are vulnerable. But, we're talking about immature bone that's being piled on at a rate that is very, very energy energy dense. You
Yeah.
know, it
Yeah.
needs an awful lot to supply that.
So does sleep and recovery, how important are these factors in minimizing the risk for bone stress injuries?
Yeah, so I think that recovery is really important.
Yeah.
Um, and we're a lot more used to tracking sleep
Yeah.
and things like that now. There are a lot more tech out there.
Yeah.
Not so much in kids, but again, maybe some of that, we know that kids maybe aren't sleeping quite so well these days, more access to smartphones in their
Yeah, exactly.
rooms. I think that can be a factor in some, but we all know that sleep is the biggest stimulus for those happy hormones that are really positive for growth and recovery and repair and all the cellular functioning that relies on that. If they're being shortchanged on sleep, that's a big risk factor.
Yeah, cool, definitely. So what other extrinsic sort of factors, external factors? We talked about sort of training load, volume.
Yeah.
Is it, different surfaces that they train on, footwear? Do these, fast bowling, I think, is also technical.
Yeah.
A mixed pattern versus a front-on bowler versus a side-on bowler, I think would increase risk profile for pars injuries.
Yeah, so I think with all stress injuries, when you look at most of the research, there are some elements of technique that are important, some elements of strength, some elements of flexibility.
Yeah.
But on the whole, those tend to be more loose associations.
Mm-hmm.
Yeah, I would say, maybe fast bowling, there are some really good studies out there. But for a lot of other sports and the stress injuries that they have, I think that sort of those sort of muscle length, flexibility, technique, those things have the smaller amount of influence over the much bigger things that we've talked about, like load
and energy
and nutrition and energy.
Yeah.
Yeah.
Okay, cool. So how big, we've started touching on this, that sort of energy availability. We talk about something called REDS, relative energy deficiency in sport or syndrome, depending on what you've read. How much of that is a factor in, say, your cricket injuries or some of your other bone stress injuries that you see? Or is it more purely sort of load related?
So I think, when the sort of red S definitions came out, I think that it was really helpful in one sense because it didn't exclude male athletes so much. And we started understanding that
it used to be known as the female athletic
triad, or female athlete triad. And I think, females, there's no doubt, have a specific set of hormone profile that is that can be very negative for bone health in sport, especially in weight controlled sports. Where
runners in particular,
distance runners,
gymnasts.
gymnasts, even somewhere there's a weight category to stay under, for example, which encourages you to obviously not have the nutrition or even if the sport requires, we see it a lot in ballet dancers where the aesthetic is often it has to be slim. So they're often much more likely to have hormonal drivers to their bone stress injuries. And, estrogen's such a key player in female bone health, both at a young age and postmenopausally, which again is something that we're seeing a swathe of in the sort of perimenopausal group of bone stress or tendon injuries because of a lack of estrogen. But I think that the red S is a really good framework because it can be applied to anybody from any age. You can there's a number of ways that you can go online and kind of within a
And assess that.
squad,
Yep.
you can assess that. You can, if you've got nutritional support, you can educate parents, etc., on how kids should be fueling, which will
Are there
help.
simple questionnaires that I know Nikki Key has produced PEAK,
Yeah.
PEAQ.
Yeah.
We sometimes use it. There's simple questionnaires that you use.
Yes,
around
there's
that.
a number of questionnaires that can be used. Some of them can be self-delivered. Some of them are kind of interview delivered. But there's a lot more data out there now that you can kind of, with an athlete within an academy, for example, screen those kids and see, you know, are they getting enough in the way of nutrition, either before they get a fracture or after they suffer a fracture.
And what markers are you looking at when you're screening those individuals? Are they blood markers?
So it depends. On the whole, I think that for a lot of younger athletes, we tend not to go down the route of multiple investigations and screening. I think if you had a professional athlete who was fully mature, then you'd be looking at a lot more hormonal profiles. You'd be looking at, you know, bone markers. Traditionally, if there's a stress fracture, we're sort of making sure that calcium, phosphate, alk phos, things like that are normal. The vast majority of the time they are, because as we said, the calcium's very finely regulated. But you can look at things like vitamin D, which is stored in the fat. You know, that doesn't change quite so quickly. So that's always something really helpful
and
to
most
look at.
of us are probably
deficient
to
some degree
in this country.
It's
unless you're
interesting.
Supplementing.
There's a lot of debate over vitamin D, and a lot of people think that it's overhyped, but the evidence in stress fractures is really, really clear. And a lot of this has come from the military again, because often they take people who are kind of 17, 18, maybe not averse. They're not used to doing a lot of physical activity. They join the army, they go through a basic training. It's very physically arduous. So the rates of stress injuries and stress fractures in the military worldwide is very, very high. So some of the best studies have been done in military recruits.
It's probably a perfect environment.
Absolutely. And we know similarly with people who get traumatic fractures and fracture repair, if you have a low vitamin D, you're more likely than someone who's got high vitamin D to have a stress fracture. If you have low vitamin D, you're more likely to have a non-union or a delayed union. If you supplement people before they do exercise regimes, they suffer less stress fractures. So I think although you can debate this sort of, some people don't like the fact that it's almost like everybody has to have vitamin D. But in my practice, it's something that's it's number one on the list
that we discuss.
Absolutely, and it's really simple. It's really safe. They really have to go some to overdose on vitamin D.
Have you ever seen anyone overdose?
I've not seen a clinical
D?
case of vitamin D. I've had a couple of patients where I've tested and they've been up at like 230, 240. And you kind of, and they've been obsessively taking, 8,000 a day for 12 months when they don't need it, sort of thing. So, but from the doses even the super doses that we use, I rarely see it go much above 120, 130.
So what does that sort of low energy availability do to the sort of microarchitecture of the bone? How does that impact, the loading that the athletes or anyone goes through and then impacts the repair process?
So I tend to try and break it down fairly simply for patients, because they're not going to understand all the physiology about, and even, it's pretty confusing for anyone who works in science, how estrogen, testosterone, leptin, these are multiple pathways. But I think I kind of explain it to them saying, your body is doing 3,000 things at once. There's all these chemical reactions going on, and it takes a lot of energy just to keep the lights on. Keep the brain working, vision, hearing, all the senses, movement, all those other things. And really, if you've not got enough nutrients, then things like building muscle and repairing bone gets pushed to the side. Because it's not essential. It's not essential to you staying alive in that moment. And I always, with all of my stress injuries now, pretty much, I'll say to them, the professional athletes at least, you know, don't worry about the fact that you're not training. Kind of eat like you are for a period of time.
Well,
And
you almost need a 20%
we're
more
aiming
energy.
for like minimum 300, 400 calorie access per day. And I sort of say, look, I know we've got smartphones and we've evolved, but when we go back to the days of when we were, scavenging for food, your body you'd come across an oasis. There'd be times of the year when food was much more plentiful, other times when not so plentiful. So your body has a way of adapting to that. And it's only going to go into the repair phase when it thinks that there's an abundance of food. So you've got to send it that message of excess calories, excess protein.
And that's a
then
hard
you
message.
Can switch that repair button on.
It's a hard message for a lot of
100%.
A lot of people to take on board. Females, males, athletes. Big and so often it's something that we really stress. Like, do not cut calories. Do not cut your intake. You need more than what you were eating before. Because it's such an energy sort of consuming process, the repair process.
Yeah, absolutely. Some of them love it because as professional athletes, they're kind of, they know that they're on that balance of almost starving themselves constantly. They're on a real knife edge of, using their calories for every single piece of protein synthesis, repair, performance, energy. And so some of them quite enjoy having a little cheat period. But I think normally the recovery from these sorts of injuries is long. So you've got to be putting the kind of, you'll lose those few kilos when you start moving a lot more and you start getting back into that. Your body works it out. The human body is incredible. And you do see this with some athletes who will cut their weight for a long period of time and they're just about holding on. Then they will suddenly then drop a load more weight if they're not getting the calories in, for example, because the body can distribute it in different ways. It's a great machine.
Yeah, it's fascinating, isn't it? So are there any early warning signs that coaches or parents or even clinicians could identify that someone's might be at risk of an overuse type injury or that bone stress injury?
I think it's really difficult because a lot of the time, you don't see the warning signs. And even it rarely affects performance until it does. And even I think one of the difficult things in diagnosis is the vast majority of stress injuries, if somebody has some back pain or shin pain or foot pain, if they went and saw a health professional the first time they had that, often the examination would be completely normal. And you see people all the time still, hip stress fracture. You examine them, nothing to find. And they just get their pain after they've done a 5K run. And, you can do a scan and see a significant bone stress injury, but a normal clinical examination. So we don't always get clinical warning signs. I think, when you're thinking about the adolescent athletes, if they're absolutely exhausted or ravenous at the end of the day, or you're starting to pick up on maybe they're avoiding food or being too picky on food or not taking food when they're offered it, abnormal beliefs about food, those are some of the other more psychological warning signs from the sort of input side of it. But that,
it's a hard one to screen and identify beforehand.
Absolutely. And I've been a parent as well. It's a sensitive area. But when kids are growing up, they're very aware of their appearance. And these are not simple things to just say, oh, you need to eat more. It doesn't work like that.
Okay, so moving on a little bit, we're going to dive back into some cricket, if that's okay.
Yeah, of course.
And talk about sort of these pars or stress fractures that fast bowlers see or get. Now, Paddy Cummins, Aussie cricket captain, and by the time this is out, we've probably finished the Ashes, and I think I know who will have won, and I hope they will have. But he's just returning from a
Yeah.
probably his third or fourth
Yeah.
round. I don't know his medical history personally, but of stress fractures. Why are we seeing that in fast bowlers? Is that just the load on and the specific biomechanics on that part of the spine?
So most fast bowlers will normally get pars stress fractures on the other side of their bowling arm.
Yep.
So that's partly to do with their bowling action. So, if they're
Because you're
a right,
closing down that
absolutely. If
space.
they're right
Yep.
arm over, they'll be going into an extension, rotation, and then a flexion.
Yep.
And I think that's an important thing because I think we've kind of the message of pars fractures are all extension related sports. That's not the case. We see it flexion, extension, rotation. We see it in rugby, cricket, football, whatever sport you want. But specifically in cricket, it's normally on the opposite side to the bowling arm. And that area of bone has to go through a huge amount of compression, shearing, torsion, rotation. And so that bone gets very, very thick. And we know that from, individual DEXA data left to right, individual vertebra, research tools. And yet these guys still get stress fractures. And we look at the England cricket squad. We did a presentation at the British Association of Sport and Exercise Medicine, and Nick Pearce, who's my CMO for ECB cricket, he presented on. He did an introduction to pars and basically went through every single white ball and red ball bowler in the England squad at that time, and every single one of them had a pars stress fracture, and some of them had missed. I think 4 of them had missed over 1,000 days of cricket from recurrent stress fractures.
Yeah.
So it's
a massive
it's a massive problem. Now, I think that again, if you talk to some of the cricketers of yesteryear, they would just get on with it.
Yeah.
And they would fracture. And then some of them would either bowl through pain or retire because they then develop secondary problems secondary to that pars fracture.
Yep.
Now, the aim is to heal it. So you maintain spinal anatomy.
Some integrity there. Yep.
But I do think that the intensity of the game, the changes in format is a big thing also. It's very different doing a fast bowler doing maybe 2 or 3 sessions of 6 overs during a day. That's still quite different to 4 overs in a T20.
Yeah.
The intensity is still different. The preparation, everything around it is quite different. So I think that those changes also play a role.
Yep. Yeah. Okay. Fascinating. So when the bowlers have this, and clearly, that's a known sort of risk factor for fast bowlers. Spinners don't tend to really, we don't see the same injuries in
Not to the same
bowlers.
extent. It's possible, but not to the same extent normally.
How long is it taking for these athletes to sort of get back into full function?
Yeah. So again, going back to some of the ECB data, they've got some really good data that was published over about 7 years of following all the professional county cricket teams.
Yep.
The average return back to bowling following diagnosis of pars injury was about 240 days, if you could believe that, which is huge.
Yeah.
So it's a
9-ish months almost.
It's a season ender.
Yeah.
Yeah. It's between 8 and 9 months, I think, really. And so often this tended to come at particular spikes in the season, either early or then another set, the beginning of the end of the season, as it were. And sometimes that was because of changes of format.
Yep.
That was a potential risk factor. And so it's a massive morbidity associated with that injury. And I think really what we've been trying to do over the last 5 or 6 years is work out how do we bring that down? What other adjuncts have we got? How do we load them? And I think, my sort of thoughts on both physical rehabilitation and the sort of adjuncts that can be used have changed hugely in that last kind of 10 years, I'd say.
Yep. What's changed then? How's your thinking changed?
So, I'm very much bone stress injuries, kitchen sink approach.
Yep.
So all the risk factors.
So throw everything at them.
Yeah, all the risk factors that we've talked about.
Yep.
The nutrition, the calcium, the vitamin D, the coaching, the loading, the strength, all those other things. But I think more in terms of what are the other medical adjuncts that we can use. And in the professionals, then we're much more likely to use other adjuncts that we wouldn't use in a standard population, because most people with a past fracture, if treated appropriately, will heal.
So a period of rest,
Absolutely.
a period of reloading, modify movement patterns, appropriate strength. Because in your elite athletes, you're probably not dealing with the strength deficits that we might see in general population.
Yeah, not so much. And they're already people with very high bone density, as I said earlier. So they're super maximal bone density in those areas where they've got the fracture. But certainly in the cricketers, for example, now we're using a lot more biophysical stimulation. So most people have heard of LIPUS, or low intensity pulsed ultrasound. We're now using, LIPUS has quite because it's ultrasound, it gets absorbed quite quickly the deeper it goes into tissue. So we're using new biophysical stimulation that might be something like capacitive coupling or pulsed EMF or other sort of adjuncts around
EMF
that.
Is
so electromagnetic field, capacitive coupling, electric field. So these are where you have a stimulation, chemical, electrical, magnetic, that creates a biological response,
a healing response.
So we might use,
as well as MBST.
MBST, absolutely. Yeah. So again, using a magnetic field to generate a biophysical response. And we think it does that mainly through increasing intracellular calcium stores. Each one has a different way of doing it, but that then kicks off calmodulin and a bunch of other factors that then make the osteoblasts that make new bone switch on and switches off the osteoclast a little bit more. So biophysical stimulation is one, and certainly in elite cricket and other elite sports, I've used a lot more of the sort of drugs that are out there primarily for osteoporosis. So bisphosphonates have been around for a long time. So how bisphosphonates work is they actually slow down bone turnover. So their evidence in the sporting world is normally for sort of bone marrow edema syndrome. So like people call osteitis pubis, pubic bone overloads. There's a bit of evidence for those sorts of things. And what it does is it slows down the osteoclasts, the things that eat the bone, but it also slows down the osteoblasts. But the net is it slows down the osteoclast more. So it has a net positive effect on bone density. However, they don't have any good evidence that they improve fracture repair. So often what you do find is that if someone's on a bisphosphonate and they're old and they get a fracture, they get quite a bit more callous because it kind of slows down that whole process. It's an extended process. So what we've used in elite sport, or what I use a lot more, is the anabolic bone agents. So these are primarily your parathyroid hormone analogs. So teriparatide is the one that's been around for 25 years. And again, they actually increase the osteoclasts. So the ones that come and eat away. So they do increase the turnover for a period. But they're much more anabolic for the osteoblasts. And so the net
stimulates.
The net is bone formation. And there's what we call an anabolic window in the first couple of months where there's a lot more osteoblast stimulation, a lot less osteoclast stimulation.
Okay, cool. Interesting. So low limb stress injuries. Okay. What are these more your running based injuries that you would see? Perhaps a little less in football, more your endurance runners?
Yeah, I think lower limb injuries in runners are very, very common. And we see them in professional athletes who are just really pushing themselves again, as we said, right on the edge of have they got all the nutrients, the calories to keep them going, the performance. But also, in our amateur athletes, we know that people go, I want to go and run a marathon. they're not necessarily runners.
Yeah.
They start a nice couch to 5K, then they do a couch to marathon program. And multiple people get stress fractures because their bones just are not developed enough to tolerate that sort of load. So it's very common: pubic, neck of femur, tibial, navicular, metatarsals. So these are all common runners' stress fractures, unfortunately. And some of that, as I'm sure you know, we were talking about earlier, is technique and ability and running style, etc.
And ability to tolerate the load.
Absolutely. And you know as well as I do, some people, when you look at a good runner, even a good amateur runner, it looks good. You kind of, that's a marvelous running gait. They look poised. Some professional runners look terrible still. But unfortunately, not all of us are built to run. And so they're inherent risks.
Do you say that to patients? Are you? I mean, generally, I feel we can rehab most people to run to a degree.
Yes.
But there might be a few people where I'm like, buddy, you're just not built mechanically to tolerate the load if you wanted to run a marathon or something like that.
I do sometimes say that.
Yeah.
And I think, I'm not saying it to be mean. I'm kind of saying, look, everybody can do something. And you're absolutely right.
Yeah.
Every human has the capacity to run.
Yeah.
But we know that some people are born to do it.
Yeah.
They're just designed,
especially the
they're
ones
mechanically
with,
more efficient.
Varus sort of alignments or changes of in alignment where they're just going to load a different portion of their knee or something.
Yeah,
you might be in trouble. Yeah,
and similarly, we're a lot bigger than we used to be. Obesity is a big problem, and that excess body weight is going to increase the load. It's going to mean that often they're weaker.
Completely.
It's lots of factors in there. So I think that what you're trying to do is help people achieve their goals, but do it safely, and advising them on how other things are going to help them along that pathway if they really want to run. And I get it, because a lot of people who do their first marathon, it's something sad that's happened. It's a partner or a parent or someone's been diagnosed. Most people do it
under a
charity.
Yeah.
And so I get it that it's such an important thing, and we've got to be there to help support them and get them through.
Yeah. Yeah. How much do I often think that, our elite athletes that we see who might have the stress fracture, probably mechanically, the nature of where they're at, there's probably less of a biomechanical component with them. And it's probably more that load and energy management. Whereas some of the non-professionals can have a higher propensity to biomechanical issues, pelvic weakness, hip instabilities, foot mechanic issues. Is that a fair statement?
Yeah, I think it's fair. What I guess I would say is that probably in the elite athletes, it's though subtle deficiencies will show themselves quicker.
Mm-hmm.
So if you've got a really good long distance runner, then and often other injuries play a big part. And it might be something as simple as a twisted ankle or a knee injury, for example. They lose a little bit of muscle mass around the quad for that period of time. That then changes their mechanics, because the body's got a great way of fooling us that we're doing okay. And
very
subconsciously their movement will change. And if they're a professional athlete, that problem will come to the fore quicker.
Yeah. Okay. So how much of an issue do you think our body's biomechanics, how much do our biomechanics contribute to stress fracture risk? So particularly in, say, the lower limb.
Yeah, I think it definitely contributes. What I would say is that sometimes we can get a bit over obsessed with the mechanics,
foot mechanics,
and explanations for why somebody's got a problem. I think that there was a big Delphi study, which is essentially where you get a bunch of experts together and say, what do you think about X, Y, and Z? And you rank a bunch of statements. There was a big one on bone stress injuries that was published last year. And so lower limb mechanics and running mechanics was deemed a relevant risk factor by the bunch of experts on this Delphi.
Were you part of that?
I wasn't part of that, actually. No.
They didn't ask you?
Well, who knows? Maybe I missed the email, but I think I'm not someone who publishes a great deal in that sphere. So they tend to be researchers in the field who've published who get onto those Delphi studies. But interestingly, multiple things that were put as risk factors, and then all of the treatments, literally out of all the kind of 30 treatments that they put in front of people, which included improving biomechanics, etc., the only 3 things that reached the threshold for agreement was vitamin D supplementation, nutritional input, and sleep. That was it. Those are the only 3 things.
There you go.
Yeah.
So that's what we need to do. Rest, sleep, eat, and some vitamin D.
Absolutely.
Stick someone in the sun.
100%. But coming back to the mechanics, I think that if you think that there's a big biomechanical trigger that is either predispose them or could predispose them again, then that's maybe something to look at.
Yeah.
But I do also, everybody's different. Everybody's got little leg length discrepancies, slight pelvic shifts.
And the body's good at adapting.
Absolutely. We are very good at adapting. So I think we shouldn't get too obsessed with it, and we shouldn't, make patients feel bad about it. It should be more in the, okay, how can we change that?
Yeah. Can we optimize this?
Can we optimize
it further?
Because in some people you can try and change their mechanics and it's just not going to work.
Yeah, completely.
Yeah.
Completely. So does running technique play a real role? We talk about someone's biomechanics, how they move, their foot posture, their knee hip alignment. Does exactly how someone runs make a big impact?
Yeah. So again, there's quite a lot of debate on this, and you'll find some papers that say there is, others that say that there isn't. I think that when I get drawn into that debate, I tend to go a little bit more towards a midfoot run. Because I think that I think it's a bit more efficient. I think that overstriding is a problem also. So
because heel striking, typically you can veer towards being an overstrider.
Yeah, absolutely. So slightly higher cadence. Midfoot strike, etc. I'm not going to get into the debate on footwear, but what we tend to see is, there'll be trends. And it's often around a trend, and it's a big change in trend. So somebody changes a technique suddenly, their body's not adapted to it, and that's what causes the breakdown in stress on an area that's not been stressed like that before.
Yeah. I mean, we often, the one thing that we change if we're looking at someone and we think their technique, we're just trying to increase cadence.
Yeah.
Like we don't try to change a lot of their technique. We have a run sort of analysis, but we're just trying to get their cadence up towards 160, 170 at least. And that's quite hard. And to do that, you've got to become more of a midfoot striker.
Yeah, absolutely. But I think it can be a very efficient way of movement.
Yeah. So we've touched on a lot of this, actually optimizing rehab and sort of recovery within our sort of process. And what separates a great rehab from a pretty crappy one? Is it
the outcome?
Yeah. It's pretty simple, really.
Yeah.
But is there? Yeah. Okay. Communication. We've talked about. We've talked about the team approach and MDT approach, optimizing sort of patient expectations, good strength work, nutrition, sleep. Yeah. They're just the differences, aren't they?
Yeah, and I think, some people can have a really great rehab pathway that's very simple.
Yeah.
It doesn't always have to be complex. I think, in the professional sphere, we're dealing with that top end of performance, and so often you do need that MDT approach to make it successful, because there are so many competing risk factors that you can get burned if you don't address a simple thing. It doesn't always have to be complex, though. I think, a great rehab pathway is one that the patient feels comfortable with, that they engage with 100%, and that they understand.
Yeah.
And if the patient is not engaged in that process and you haven't found out what are their thoughts and beliefs and concerns and goals, that's not a great rehab process, because they won't engage and you won't get the result that the patient wants. You might be thinking this is going to get the result I want, but that might be very different to what the patient actually wants.
Okay, cool. So we've covered a lot. We've done super well, John. I've had a massive list of questions, and you've been great at sort of weaving your answers to follow.
Dodging.
How do you deal with the patients that are a type A personality? They're driven. They just want to do more and more and more, versus the very cautious patient who's worried, or the hypervigilant patient. How do you vary your approach with those different types of patients?
I think what I tend to do with the ones that push way too hard, that are obsessed with their numbers, is to try and sell them on the longer term improvement. So trying to say to them, within this rehab process, we're not just trying to fix this broken bone. What we want to do is improve your performance. And that might be doing something different that you don't normally have the time for. And I think, especially with elite athletes, that's really important. Because they're frustrated, they're not playing, they're not,
So what else can you do to optimize them during that period?
Because often when they're in the middle of a season or they're middle of training, they don't work on all those other things.
Or it might be lots more core work, or
absolutely
a bit more mobility, or
So it's trying to tap into what drives that not overachiever, the type A, the driven, that, got to be doing things, got to constantly be doing things. So you can then say, okay, well, let's look at elements of your technique, or your stability, or your balance, or your vision, or your, engage them in that process of them going, oh, okay, so, actually it's going to be,
there's something else we can do.
10 minutes on this problem, but there's a load of other stuff I can do in the gym that I've never done before. And you've got to reel them in that way. And that can be difficult. I think with the super cautious, a lot of the time, you kind of, it's not a big worry, because you worry with bone stress injuries, the ones that push too quick. Because they're more likely to fail. The ones that go really slow are much less likely to fail. They'll heal, but they may not develop the resilience that stops it happening again. So I think, again, with those people, you're much less concerned at the time. But again, what you don't want them to get into is that sort of kinesiophobia, fear of movement, hypervigilant, I've just felt something in the muscle. Again, that's communication, reassurance, good pain, DOMS.
Versus bad pain.
And
that can be hard with bone stress injuries. And that rehab process back.
Because on the whole, the vast majority of bone stress injuries, you kind of want your patient pain-free. Because, bones do not give us a brilliant feedback. We were talking about pars injuries earlier. The biggest problem in pars injuries is that often you take a kid who's 14, offload them, 2 weeks later, 3 weeks later, pain's gone. And the problem is, unless you understand that injury, you kind of start going, okay, well, let's start getting back into things. And then you get to 6 weeks, and then you convert a partial into a complete. And then you convert a complete into a bilateral. Then you get into this really bad phase. So, bones aren't very good at giving us feedback. You want them to be pain-free the whole way along. So that's where we really need the experience and the imaging, the modern imaging that we have, to help guide that sort of return to play, as it were.
What imaging modalities are you using for most of these? You're using MRIs, you're using sort of different sequences like the STIR sequence or...
Yeah. So I think, the availability of MRI has definitely changed the game. Previously it used to be X-rays.
Yeah.
And
SPECT CTs.
Yeah, well, it used to be X-rays or bone scans or SPECT CT. All of them have radiation, and CT and SPECT CT, bigger radiation load significantly than X-rays. X-rays, not particularly good, not sensitive at picking up bone stress or small fractures. By the time you see it, you kind of missed it. So MRI has been fantastic at showing us bony anatomy. The fluid sensitive sequences or STIR sequences, those will light up in areas of bone. What MRI is not so good at is bony architecture.
Yeah.
And so specifically for PARS about 7 or 8 years ago, we started using a specific sequence called a vibe sequence.
Yep.
So that's just particular to a particular type of MRI machine. There's a number of other ones, but essentially what you're using is an inverted T1 image, which gives you more bony anatomy. And we found that to be really, really helpful in PARS injuries.
More sensitive.
It's very well validated. So it's about 97% sensitivity, specificity compared to a CT scan, but no radiation.
But no radiation.
Very repeatable. So you can take a kid who's 14 and do 4 MRIs over 8 months without worrying that there's any risk to that child from a radiation exposure. So, that's a fantastic advance for us. It's not, the vibes haven't been particularly well validated in other fractures, although I use it a lot. Still, it's not been so well validated. I think that we do very occasionally in the pro athletes, we might use a CT scan if we really need to know.
If you're chasing something.
Absolutely. If we really need to know, and very occasionally we might use a SPECT CT, which is where we do an injection that goes around to areas of increased bone uptake. So it's all about what's the risk versus reward. I tend to use, obviously, the CT and SPECT much, much, much less frequently in a non-elite athlete because it's not their, it's not their job, and
that makes sense.
Yeah, absolutely.
So just touching on REDs and some of the deficiencies that patients might have in terms of that energy deficit. Are you sometimes using DEXA scans in some situations where you're picking up and going, could this be a bit more of a global problem that we're seeing or a systemic problem?
Yeah, so DEXA scan or body composition scanning. And there's lots of different things out there. So traditionally, a bone density scan or bone mineral density scan, if you go for one of those on the NHS or you go for one regarding bone health, it tends to measure the lumbar spine and the hips. And the reason for that is that those are the two areas that when we get old, get thin bones, osteoporosis, and those are the ones that can fracture. So within the spine, that can be, they're often just spontaneous, non-trauma related. You can literally be sitting down and you get a wedge fracture of one of the vertebral bodies. With the hip, it tends to be more, again, you fall, and you fracture, you get a fractured neck of the femur. And it's a marker of frailty. If you have a neck of femur fracture from a fall, the data on mortality within the next 12 months is astonishing.
It's very high.
It's a marker of frailty. So a DEXA scan specifically looks at the bone density of those two areas, and then it will give you a statistical score which will compare you to everybody your age. But the score that's used to define osteoporosis is what were you or what should have been your average when you were about 30 years old, which is where between 25, 30 is our maximal bone density. So it's what are you compared to your peak? And that's how it can be used from a data perspective to make decisions on treating osteoporosis. What we're using a lot more nowadays, what people are used to, is body comp scanning. So you're looking at fat mass, muscle mass, you're getting a global bone density. And again, I think that it can be
Are you
really good
using
for
DEXAs for
performance.
that? DEXA body compositions?
Yeah, you can
Yep.
do.
Yep.
Yeah, absolutely.
Yep.
Yeah, and the idea there is more information. And
Yeah.
listen,
Yeah.
we're living in a world of data.
Completely.
And sometimes more information is good. Sometimes it can cloud
Yeah.
the answer
The
that you're
picture.
looking for, or it can hide the one thing that's really important.
Yeah. Yeah.
But I think it can be tracked. You know, the DEXA can be sensitive at change.
Yeah. Particularly with muscle mass and these
absolutely.
energy deficit
Yeah.
sort of
Yeah.
athletes or individuals
Yeah.
that we see. And, you know, muscle mass is, sarcopenia is a real problem that we're seeing
Yeah.
across the board, and particularly with some of our sort of Monjaros or GLP-1 agonist sort of
Yeah,
drugs
absolutely.
that are becoming very, very popular.
Yeah.
Do you ever we use a lot of REMS, echo-like REMS
Mhm.
scanning, because you touched on that DEXAs don't quite give you that bone architecture.
Yeah.
And I think there's a toughness aspect to the bone that we like to understand, because it doesn't seem that bone density is the one.
It can't explain all of it.
No.
Yeah, absolutely. And there are other newer techniques.
Yep.
You know, high res quantitative CT scanning is a sort of more of a research tool, and even a lot of the DEXA scans now are giving something called a trabecular bone score. So again, we're starting to understand a little bit more about how do we piece together all the information about the microarchitecture of this particular bone. But even if you've got research tools, it doesn't always give you all the answers about who's gonna fracture and who won't. But certainly a lot of the work that's done with the research, highly specific DEXA, looking at individual elements of each vertebral body side to side, that the ECB have done, they've over many years got a real normative values for county cricketers.
Okay.
They've got normative values for those who suffered stress fractures, and there are clear differences.
Okay.
And you can see how the curve in a developing cricketer should look.
Yep.
And how, if they get a stress fracture in their developmental years, that stops the curve from going up. And so it puts them more at risk of that second
further
absolutely
stress fracture.
And so, we are gradually getting a lot more information on what does it mean to this particular injury, and how can technology help us.
Yep. Okay. Interesting. Yeah, fascinating stuff. I'm aware of time, but so what are a couple of takeaways that athletes might be able to think about, or individuals who exercise a bit might be able to think about, to reduce their risk of bone stress injuries?
Yeah. So I think that obviously we talked a lot about load, and we talked a lot about nutrition, and we talked a lot about sleep. So the three takeaways from the Delphi, vitamin D.
Yep.
If you're in the UK, from about September to April, you're not going to make any from the sun.
Exactly. Yeah.
So I think that thinking about vitamin D supplementation is important. If you have particular dietary needs and you're not getting a great deal of dairy, etc., you might even want to think about some calcium supplementation. I think if you are, let's say, a runner, or you're someone who is in a sport, you're not elite, that is a high risk of stress fractures, like a runner, then I think having a look at your total training volume, mix things up a little bit.
Yep.
Have some down weeks.
Yep.
Have low intensity weeks. Make sure that some weeks you're getting an extra rest day.
Yep.
Simple things like that are really effective.
Yep.
And even, I love the concept of a bone holiday. And there's a great paper looking at rats and femur bone density when they load them consecutively, or load them for a period of time, then a bone holiday, then more loading. And in terms of risk of fracture, strength of bone, when you give your bone a little bit of a break,
it responds positively.
It responds really positively. And then you go again. And I think, a lot of runners who get these stress injuries never have a week off.
Yeah.
They never have a weekend off. They never,
Yeah.
and that's what drives them, and that's what they do. But they can definitely reduce their risk by thinking about putting those little gaps into their training regime, or even just periodizing things. Lower load week.
Yeah. Okay, cool. John, that has been amazing. Super insightful. I've learned a lot. I hope everyone's enjoyed listening to you. The guests can find you at Fortius Clinic.
That's correct, yeah.
But we could have gone on for a lot more.
Yeah.
But thank you so much for your time.
Fantastic. Pleasure. Thanks for having me.
No problems.
Cheers.